Hello, everyone, and welcome to the CoROM podcast. This is where academic medicine meets remote, austere, and resource-limited areas.
So welcome to the CoROM Conversations, and we are going to hear from Zach Andrews, a soft medic, about one of his patients he had. And this is an open conversation, so do please raise your hand and ask any questions within the messaging, and I'll keep an eye on it. But Zach, I'm looking forward to this, brother.
All right. Thanks, Aebhric. Thanks, everyone, for logging on today. So this is a clinical case that had a profound effect on me and really shaping me as a younger medic and trying to figure out kind of who I was and who I wanted to be in the world of medicine at this point. And so this really isn't a textbook scenario. This patient actually presents quite atypical. And essentially what happened is a man walked into a tent under his own power. And physiologically, he shouldn't have been able to. And that's one of the things that had a significant shaping on me. And the rest is how deep just in how rapid critical care medicine can revolve around a patient. But the fact that he was walking in is one of the most important teaching points that we have through this entire session. It can be deceptive how severe illnesses can be, and we can kind of be lulled into a false sense of security and think that someone appears relatively well. And this isn't just within remote medicine. This is within, you could be at the emergency department or working EMS and, doing calls. And so it's a great lesson to learn across, but most specifically remote medicine, you usually don't have the time or the backup. So in remote medicine, your mind should be focused more on what is hiding and what am I not seeing versus kind of getting in that sense of security. And we're going to walk through the clinical decision-making process for this patient, the drugs, the equipment, where I was in a general aspect, and we're going to go through settings. We're going to do a lot on here, and I'd like this to be a conversation, not so much a lecture. I don't have any trick questions. I really ask that everything here has a clinical grounded evidence that I present. And if you have a comment, please jump in and defend your reasoning. So what I will say is Aebhric there's a Word document that we can post. Maybe if we put this on YouTube, maybe there's a way to post it in the description. But to further elicit learning out of this, whether you're a BSc or MSc student, there's a Word document with questions that I have per slide on here. And it's really just to help you drill down and get some clinical reasoning going on. If you're a BSc student, I just worry about the BSc side. If you're an MSc student, obviously it's going to take you that further step, but maybe look at the BSc questions too and make sure that you don't have any gaps that you need to work through. So before we get into this, let me just kind of frame what we're trying to achieve today. The objectives are not just boxes to check off. Each of them represent a clinical skill that could save a life. And by the time we finish, I want you to be able to look at a patient in a remote environment with limited resources and make sound, defensible, evidence-based decisions under pressure. And that's the standard that we're going to work for. For the BSc students, we're focusing on recognition, application of framework, and understanding a rationale behind clinical decisions. For our MSc students, I want you to operate at a higher level. I want you to critically evaluate evidence, question guidelines that maybe I used or maybe what you would use, in thinking about the systems and human factors that shape the clinical outcomes. Both levels of thinking are valuable, and the Word document directs questions in that area towards both of them. Okay, so the scene, let me paint this picture for you. So we're in remote Africa. Remote Africa. There's not a hospital that is close by. There's not a clinic. There's not a resuscitation bed. There's not a crash trolley that is in the infrastructure of this place. What you see at the top right is actually out of. You can tell it's the walls, if you see they're curved there. It is a tent, and the floor is the covering on it, but it's just a plywood floor that's under there. And over time, we managed to get a significant amount of equipment in there for a true ICU. But there's no CT. Labs are very limited through staff, but we did have X-ray. In the bottom right is a Minex portable X-ray, but we had no X-ray tech. So as a medic, I learned how to do labs. I learned how to shoot X-rays. You really become a jack of all trades at that point. Now, for this patient, the first thing I will kind of put in front of you, this patient had been unwell for 3 weeks. And in the last week of that, nobody had actually really encountered him. This is really kind of poor judgment in multiple aspects of the company he worked for. Kind of just thought he was on a bender or needed a break. Unfortunately, that's where they kind of work with them. But really what was going on is he actually had a infectious disease. And for 3 weeks without treatment, when we get to here, I won't break out to exactly what he had. Hopefully I didn't put it on the slides already. Once we build the differential, I'll kind of go into what he actually had. But with this infection, every day that passed, he was getting much worse. And so what really caught the attention, he was on an outstation that was actually a little bit further away. It was a good day's drive through the bush. I mean, it was a hard day's drive through the bush to get there. Ideally moving by some, rotary wing or fixed wing aircraft to be able to move in between places. But he ended up walking into the dining tent, and as the dining tent looked much like the resuscitation tent that you see there. And he actually lost incontinence in front of his colleagues there. And then they started questioning him, of course, of what's going on. And he's like, I just don't feel well. And they determined, something's off here. And so there was a medic who was out there, had a much smaller aid station, much less equipment, but he wasn't a joke of a medic. Actually, he was a experienced RN who worked in an emergency department. And one of the learning points here is he was actually hesitant to send the patient to me, even though my clinic had much more capability and was actually closer in the links to definitive care. I was really the last stop before we get you to some really nice high quality care elsewhere on the. And, with that hesitation that medic had, it has clinical consequences with it. And as capable as he was, kind of the first question that I have to put in front of U.S. students, if you were the medic at that outstation and he, though lost incontinence, was still A&O times 4, GCS of 15, was able to communicate freely with you, move under his own control, what would you have done? And you have to be honest there. What risk are you actually assuming by keeping him? And what's your red flag that you're going to send him out? Or what are you kind of explaining away in your mind to hold on? Or would you have sent him? And so essentially, he stayed there about 24 hours before I was able to convince that medic that you need to get him over here. And we were able to spin up an asset to be able to get him to me. But that was a whole 24 hours that had elapsed. And it was a delay in care for that patient. So the patient arrives at my location. What I see is, again, 24 hours later, it's a man he's alert and oriented to some place, time, event, GCS of 15. He's talking. By the most basic neurological assessment we have, he appears intact. But if you look a little bit more carefully, he's pale, he's rhetic, just sweaty, he's shaking a bit. And this isn't kind of a subtle tremor. What I noticed is he had this large cup, and we get from gas stations, as we call them in the US, or, I guess pet stations probably elsewhere are the same, but they had this big gulp. It's made to just put a egregious amount of soda to cause diabetes in it over your lifetime. And he had it full of ice. And as he was walking in, I just distinctly remember the ice rattling inside of it. And I can still hear it to this day. And so that's just one of those subtle signs. The body is working extraordinarily hard just to maintain its basic function. Now let's look at those vital signs. And this is really where it started clicking with me that something is wrong. A blood pressure of E4 over 50. How he walked in with that, I'm impressed. a heart rate in the waist. Temperature was approximately 100 Fahrenheit. Sorry, I didn't do the, I did do it. It's 39.4 degrees Celsius. Two of 97%. You know, some of those are concerning, but overall, some of those, they're not too bad. 97%. Body's trying to maintain its cardiac by increasing that heart rate because the stroke volume on this patient is failing, and we know it's failing because look at that blood pressure. That's not a good blood pressure. That temperature tells us there's a significant infectious process driving a systemic inflammatory response. We'll kind of come back to that because when we see some blood gas results that I had, that number will take on a very different. Keep that in mind. SpO2 and 90. So what would you say? Is this patient in shock? So what type of shock? He walked in under his own power, GCS of 15. It's deceptive, but yeah, the patient's in shock. Patient's in distributive, a septic shock. I didn't tell you what I already knew at this point because I don't want to break down your differential and kind of lead you with that. Patient's in septic shock here. So if this patient walked into your austere clinic or your emergency department or wherever it is that you work with these vital signs, what would your first three actions be? You know, let that kind of process in your mind. What would those first three actions be? What would you do immediately to make this patient better? Or what processes would you put in motion to get this patient to a better situation? So now this is why I love remote medicine, because now we have a problem within a problem. Now you're in a tent in Africa. What changes the way you approach this patient or the problems that you have?
We have comments of do a news score, do a fluids, do a malaria test, take 3, give 3. I'm not sure what that is. So here, those are the comments coming in so far.
Great comments. I like where you went. News score. Unfortunately, at this time, I actually wasn't familiar with the news score, but that's great. That's a great score to be grabbing. The malaria test. Hey, everything's malaria in Africa till it's proven otherwise. So good on you for that one. The take 3, give 3. I'm not sure what that is, but
Dimitro raised his hand. What do you got?
Thank you for this opportunity. I would say this patient is very lucky because having malaria for 3 weeks with the fever, most likely the parasitemia was very high. So if this guy would be present in my clinic, I would try to stabilize his blood pressure as soon as possible and find the reason for this kind of symptoms of fever. Do the malaria test definitely and urinalysis, and depends what kind of laboratory capabilities you had there. Investigate deeper for the septic shock.
Yeah, great. So to drill down further on that, so I had microscopy, I could do staining, and then I had some RDTs. With that, where do you think you'd go with that? RDTs being the rapid detection test.
What do you mean about RDTs? What's the question?
Yeah, we'll get into it. So for RDTs is the rapid blood test, similar to like a rapid influenza or rapid strep test, things along that line. But they have some for malaria specifically, and we had some for various different diseases that were tropical in nature.
We have a question for Dimitro Petra.
Hi guys, it wasn't a question. I wrote the take 3 and give 3. So usually with the news score, you take 3 diagnostics and give 3 treatments. But again, I was just thinking about the septic shock, not the malaria issue. So that's why I said the septic shock. Because in my opinion, that should be treated first. So the take 3 is like, for example, like blood cultures, blood tests, and I don't know, urine output, for example, and then give 3 oxygen in case his SATs were not good, but he had 97. IV fluids and IV antibiotics, that would be my first course of action. But then again, we are talking about Africa, so I would go with the malaria test as well.
Yeah, very good. I like it. I like where you're thinking with that. I like the take 3, give 3. I'm going to have to remember that one. So what's your differential? We talked about area, so let's just put that at the top of the differential. What else? You're in Central Africa and this patient. Immediately, what else is hitting your mind?
Yellow fever, typhoid, cholera.
Yeah. If I can throw in, though remote, there is travel between, urban and rural places. So I'd be thinking of things like dengue fever, thinking of gastrointestinal was common for us at this point. We got wrecked by poor food choices multiple times. Yeah. So there's a few other we can add in there, but there is
Comment on dysentery as a differential
Mm.
diagnosis.
Yeah. Yeah. And that's great because we actually did have a couple bouts of dysentery. I was one of those that fell casualty to dysentery while we were out there. So we'll talk about the diagnosis here. After this patient got to me, it was suspected malaria, and so I used what's a brand called Bionex now. And the only reason I use that brand is because that's what was FDA approved. And, from the US, that's what I had. It's not the only one. There's actually better and cheaper diagnostic tests that are out there too. But I had that and I ran it in the results, and I have a picture that shows it a bit next, and we can talk about it, was so immediate and unambiguous, so strongly positive for Plasmodium falciparum that I actually had to do another test because I thought, well, maybe something is wrong with this. So usually that has to develop over 10 to 15 minutes to show a positive. And as you could see the sample moving towards the line, it was positive immediately. And so I actually got our newest batch just to make sure, the latest to expire, and grabbed it, opened it, ran it, an exact same thing. And so I think that's something to, bit. I ran a second test. I didn't just grab it and move on. And why? Because it wasn't typical in the way that presented as a positive. And I wanted to be sure. And in the resource limited environment, you can't afford to be wrong for very long. Okay. Because you're going to paint yourself into a corner. And then to be able to get out of that may be impossible. If it was a false positive, would I have been treating this patient for something they didn't have? If it was a false negative, which is less likely, but still. It could mean missing the diagnosis entirely. So I ran a second test, from a different batch, and it just eliminates the possibility of specific manufacturing error. That is, it's sound clinical governance. You do have to worry about your resources, but I was fine with that. And this is a kind of thinking that you should put on a bit in these situations. Now, if we apply the sepsis framework for this patient, which I applied the sepsis framework back then. I didn't do the new score, which is a great one too. Does this patient meet the criteria for sepsis, septic shock? Suspected infection? Yes, we have that. Organ dysfunction with a SOFA score of 2 or more. We'll see some evidence in the labs for that. And then for this patient, they're going to end up needing vasopressin or a vasopressor. I actually ended up needing norepinephrine. And so this patient falls in there, and his lactate was enormous. You'll see it here, or it's actually here in the second to last one. A lactate of 14.36. He wasn't just sick. He exceeds all those criteria by a significant margin. So if you're unfamiliar with the rapid diagnostic test, we'll chat about that here. Again, I have no stock in Bionex Malaria, and actually, I took a tropical medicine course years ago in the Gates Foundation. Deputy director of malaria was giving the presentation on malaria. According to him, he actually said the tests that you get in Africa are better than the Bionex tests. So I don't say this is what you need to use. This is what I had and what I was allowed to use. And very easy, simple test if you're not good at microscopy. It's quicker. It buys you a little bit of time. You can get a blood sample on a capillary tube, or for you over in the UK, a capillary tube, as I've been corrected. It's just that, a card in a reagent, and the reagent is a little bottle with the A on there, and you end up transferring blood to the card with the capillary tube, and then you put the prescribed amount of drops and it's all labeled within the card when you open it, step by step, how to do it. And you should have a result within 10 to 15 minutes. And really phenomenal. They take up very little space. I mean, even if you're working out of an aid bag, you could carry a couple of these and you probably wouldn't notice that you had it. The developer, the little dropper, it's the size of an eye drop. And so that's what I used. 2 of them and immediate results. As soon as that sample hit that test line, it was positive. So what I will show you here, I went too far there. So actually the blood gas on the left is actually from my patient. Now on the right this is an iStat. I didn't have a picture of the iStat I used. That's not my patient. Please don't confuse the two. But that's what an iStat looks like. So I end up getting a blood gas on this patient. To treat him, before I got here, I did get IV access. It was pretty painful to be able to get IV access on this patient. But after that, I was able to start a fluid resuscitation of 30 mLs per kilogram, and which he was a rather large guy, so it was a good amount of fluid. And while that was going, I grabbed this VBG. And I want to start with something critically kind of important here too, before we look at a single number. So this is a VBG. It's not arterial. It is venous. So if you're going to do this, understand that your baseline is going to be different for what a normal value. And that can be a common source of error in clinical practice. So make sure that you label it as a VBG too if you send it up and out to somebody to read. And so we're sampling the blood. The important thing with the VBG, it's already delivered its oxygen to the tissue and it's returning to the heart. So the values we see reflect what the tissue has already done with that blood, with that oxygen, right? Not what the lungs have really put into it. So the venous pH is typically about 0.03 to 0.05 lower than the arterial. And the venous PCO2 is typically 4 to 5 millimeters higher of mercury than arterial. And the venous PO2 is essentially it's not really useful for assessing oxygenation. We can't use it to tell how well the lungs are really working. But with that in mind, let's look at these numbers. The pH is 7.0, even accounting for the venous correction of, on the high side, of 0.04. The estimated arterial pH is approximately 7.06. This is catastrophic acidemia. If you're not aware, anytime you get below 7.2, you don't work the same way that you were, especially the cardiac tissue doesn't work the same way. And that's probably a great indication of why he was not able to maintain a blood pressure and was decompensating. So now let's look at the PCO2. It's at 30.4 millimeters. A venous sample, the normal range is 41 to 51. And so this is quite a bit lower than the normal range, and that's extraordinary. It means that his arterial PCO2 is approximately 25 to 26 millimeters of mercury. His body is hyperventilating so aggressively right now, trying to blow off CO2 and compensate for that severe metabolic acidosis that his venous PCO2 was paradoxically low. And yet, as we'll look in a moment, even the extreme hyperventilation was not enough to fully compensate. The lactate, as we talked about earlier, was 14.36 millimoles per liter. Normal is less than 2. A lactate above 10 is associated with extremely high mortality. And in most published series, past 10 is really kind of unseen to live through. And with his, we're in a territory that's, it's incompatible with survival. This is not a number that tells you the patient's sick. This is a number that tells you the patient's tissues are dying. Now, if we look at the venous SaO2, it's 20%. Normal venous SaO2 is 70 to 75%. So the tissues normally extract about 25% of the oxygen delivered to them. Tissues were extracting about 8%. So the body's in extremis here, stripping every bit of oxygen that it can from the blood because delivery has collapsed so catastrophically. So remember back to the SpO2 of 97, and now the venous SaO2 on the blood gas was 20%. How do you reconcile those two numbers? What we just talked about it, but think in your mind, what does each of those tell you? What is truly happening to this patient here? I said it earlier. I want you to really understand of what is happening, and you need to understand what is not spoken in those numbers. So here's chemistry panels, and these are all on the iStat, and these are my actual patients' panels. And this is where this full picture of multi-organ dysfunction becomes undeniable. The sodium is 122 millimoles per liter, which normal, if you're not tracking, is 135 to 140. Best way I remember the last two numbers of each of those is because your pH is normally 7.35 to 7.4. That makes that a little easier to remember. So severe hyponatremia at this level, and the sodium affects the patient's neurological function, cerebral edema, confusion, and in severe cases, seizures and a coma. And yet this man still, within these numbers, he still walked in with a GCS of 15. Again, going back to patient didn't present how we would have expected this patient to. His brain was functioning outside of having a sodium so low. And it really tells you about the remarkable resilience of the human body and also how close to the edge he was. Now, the blood urea nitrogen, or the BUN, was at 96 and the creatine at 5. Those two numbers paint a picture of severe acute kidney injury. The kidneys were not being perfused, and therefore they weren't filtering. They weren't really producing much urine at this point either. I did get a Foley on them at some point to be able to check urine output. Very minimal. But that's where the waste products should be cleared, and they're accumulating in the blood. This is acute tubular necrosis driven by prolonged hypoperfusion. The CKMB is at 39.8 nanograms per milliliter against the normal, which is less than 5, tells us that his heart is under significant stress. In the septic shock, this is cardiomyopathy. Mediators released during sepsis directly impair myocardial contraction. Cardiac event, this is the heart being damaged as a bystander. It's a secondary effect on this patient. So the IN, or the international normalization ratio, is 1.8, and the prothrombin time is 21.3 seconds. So even the clotting system of this patient is beginning to fail. This is the early picture of DIC, or disseminated intravascular coagulation. An inflammatory cascade that is destroying the kidneys and the lungs and is consuming clotting factors. If this patient has survived longer without treatment, we would expect to actually see frank bleeding from multiple mucosa sites on this patient. And the anion gap on here is 28 millimoles per liter. Normal is 8 to 12. That gap is almost entirely explained by that lactate of 14.36. And the body is producing acid faster than it can clear it, and that acid is accumulating in the patient's blood. So we just talked about it, but looking at this chemistry panel as a whole, how many organ systems are failing? In any that I missed in here that you think are failing? And which one do you think is most life-threatening?
Multiple liver is a answer from Alfredo.
Yeah, multiple are going. This patient is in MODS, right? Multiple organ dysfunction syndrome. Didn't have liver panels on here, but I would assume that the liver is failing also. Well, but we did have the prothrombin time in INR, so I back up. We're assuming that the liver is failing because it's not keeping up. The kidneys and the heart, and in the heart being the most vulnerable here, it's additive process of MODS and struggle deep. So this patient's not in a good situation right now. And if you do get in your Word document, I do have a question that it walks you through the calculation of anion gap in the BSc level questions. I recommend, a little bit proud of myself, but I think I give you good questions if you're not familiar at reading some chemistry panels that will help lead you into some conclusions.
I put the link to that document in the messages, guys, so you can download it from the CoROM Google.
Perfect. Thanks, Aebhric. Let's talk about the vascular access. So I did give a hint, and you were all right on the money that we had this patient and we needed to resuscitate this patient. The vascular access in this patient needs to be talked about because it was not straight. When a patient is in septic shock, the peripheral veins, they have no pressure. I mean, they just collapse. You try to, you put on a band, and it's just nearly impossible to get anything on this patient. The body is shunting blood away the best it can, and truly it's distributive, so it really can't in this one that well. And the ones that you'd normally cannulate easily, they're flat, they're fragile, they're difficult to find. And this was a frustrating time critical challenge in managing a shock patient in here. So eventually did achieve peripheral access and immediately commenced crystalloid resuscitation. And after that IV stick is when we got labs. So, that's excellent practice. That's how don't need to wait on lab before you necessarily start treating your patient, especially the hypoperfusion. Every minute of delay without fluid resuscitation is associated with worse outcomes. And peripheral access of one line really isn't enough. If you've ever managed a true ICU-worthy patient, you know that you need multiple lines and drips. You see them in the hospitals, and there's pumps everywhere and things on these patients. And so, not confident to be able to get another line. What was actually inserted is a IJ under ultrasound. If you've not used ultrasound to place IV catheters, I highly recommend it. It gets you out of a pickle. It gets you out of the way of having to default to an IO. I much rather prefer getting ultrasound guided IV if I can over IO. Now, the IJ is not a routine act. It does require a bit of skill and confidence, but overall, if you can do IVs under ultrasound, you could do this patient. But it was the right call. It gave a reliable, large bore central access for the vasopressor, which was going to be placed in this patient. It was needed after 30 mLs per kilogram of crystalloid was the surviving sepsis campaign recommendation. The blood pressure had only slightly improved. Patient's vasculature was so profoundly dilated that the fluid alone could not restore perfusion pressure. And so norepinephrine was commenced. And it did bring the map up to some degree, but overall the urine output still remained relatively low, telling us despite the improved blood pressure, the kidneys were still not being adequately perfused. And the organ damage at this point was already likely too advanced. Stopping at 30 mLs per kilogram. One, I think it's important for you to recognize the nature of the shock when they get to here, but also to understand the risk of more fluid. And so I was taught by one of the best physicians, very unlikely physician to be working with me at the time, told me the first pressor in septic shock is fluids, the second is fluids, and the third is fluids. Your backstop at a minimum is 30 mL per kilogram, or really at the maximum is 30 mLs per kilogram. I apologize. Why is that? What are we risking here if we continue to do more?
Alfredo mentioned artesunate for the malaria as well as your fluids.
Yeah, our artesunate is the answer. Actually, I did not have artesunate, and I'll get to it in a little bit. What I actually had was IV quinidine, and that's all I had, but what you have is better than what you don't have at the time. So pushing the patient past 30 mLs per kilogram of crystalloid fluid really start to risk fluid overload for this patient, which could stress the heart further, and also, most importantly, the pulmonary system. We could have a shift pulmonary edema. And in fact, many remote practitioners are starting to be on the shyer side of crystalloid fluid resuscitation and starting to reevaluate the patient at about 20 mLs per kilogram. There's multiple studies you can look at, but the one I recall was done in Vietnam, and they actually stop a bit earlier because in their ICUs, they did not have the same capability that many other ICUs had that were successful with 30 mLs per kilogram. Specifically, they write ventilator to patient ratio and things like ECMO and our respiratory therapist and such. in their clinics. And so they actually had a better outcome of patients in the long run to limiting fluids a bit more. I believe Kenya did a similar study on that. It's something I should have put that in my notes here to tell you, so I apologize to that one. Pressed into ventilatory failure. Body had been working so hard to compensate for metabolic acidosis, breathing fast and deep, trying to blow off that CO2, that eventually, with that pH, with everything going on, with just the sheer fatigue, the muscles could not sustain the effort. So when ventilatory failure occurs in a patient with a degree of metabolic acidosis, it's a pre-terminal event, and that's something that was recognized. But RSI in a shock patient is a high-risk procedure in emergency medicine. The drugs used to facilitate intubation can cause cardiovascular collapse in a patient who's already hemodynamically compromised. In the act of intubation itself, the laryngoscope, the positive pressure ventilation can cause a precipitous drop in blood pressure. And if we take over the patient's ventilation without matching the rate and depth that they were achieving spontaneously, we can actually cause a catastrophic worsening of the acidosis. This is not a procedure to rush into without preparation. And to prepare for RSI, you can use the SOAP-ME mnemonic. There's also the mismade mnemonic, which is pretty similar. It's whatever you remember. Everything was checked and confirmed before a single drug was given, right? And that's the standard that you should be doing. And ideally, you recognize, as we did, this patient was going to go into respiratory failure before we got there. So for induction, ketamine was chosen. Ketamine is the choice for RSI in hemodynamically compromised patients. Another common one used is etomidate. And unlike propofol or midazolam, which causes that vasodilation and myocardial depression, ketamine actually stimulates the sympathetic nervous system. It maintains a heart rate and blood pressure, and it's also a bit of a bronchodilator, which is useful in that pulmonary edema. And critically, in this environment, it's temperature stable too. Very important for us. Not needing refrigeration in a tent in Africa matters. For the paralytic, vecuronium was chosen over succinylcholine. And succinylcholine can cause a transient rise in serum potassium, typically about 0.5 to 0.1 millimoles per liter. And in a healthy patient, that is inconsequential. In a patient with severe AKI, though, a kidney injury, a potassium that may already be higher than the measured 4.0 because of a impairs potassium excretion, the measured value may not reflect that true intracellular burden, and that rise could trigger a fatal arrhythmia. So vecuronium was safer choice. And it also, like ketamine, is temperature stable, which again, it matters. So here's my question to you for this slide. You're about to intubate a patient with a pH of 7.02 who is breathing at 30 breaths per minute to compensate. You intubate and you say you end up setting the ventilator to 12 breaths per minute. What did you just do to that patient? So what you did to that patient is you forced them to stop compensating. The one thing that was, though they were way outside of tolerance, the one thing that was really stopping them from just going off the cliff, you turned it off. So now we could expect that pH to decrease even more and really put the patient in a dangerous situation. So once the patient was intubated and the tube was confirmed and positioned by of course, a good direct visualization. We also had in-tidal and a chest x-ray. So the ventilator that I had is the Zoll EMV Plus. It's a transport ventilator, and we used a lung protective strategy. Now here's where the ventilator management of this patient becomes genuinely complex, and I want you to think carefully about this. Standards approach to ARDS patient, ARDS ventilation is the ARDSNet protocol, something to become very familiar with if you're not. They recommend 4 to 8 milliliters per kilogram, but really starting in the middle at 6 milliliters per kilogram of ideal body weight. If you're not familiar with that, please go look that up because it's not just based on height or based on their actual weight. So it gives low tidal volumes and it can allow a little bit of permissive hypercapnia, but you accept a maybe slightly higher CO2 in exchange for protection of the lungs from barotrauma, and that's the standard in these patients. But in this patient, permissive hypercapnia was not so much of an option, and we placed this patient on a very high respiratory rate to try to maintain that compensation. And again, we talked about this because the patient's pH is 7.2. I didn't talk about his bicarbonate earlier. I meant to, I apologize, but his bicarbonate was at 7.9, which a normal is bicarbonate 22 to 26. His entire acid-base system was on the edge of collapse. The only thing keeping him from failing further was his respiratory compensation. That hyperventilation is just blowing off that CO2 as quickly as it possibly could. Letting him fall anymore, really risking cardiac compromise. We already talked about the cardiac effect of 7.2, of a pH of 7.2, is where that starts to disrupt it. The further you go, the worse that gets away from there. Ventilator rate, as I said, was 20 to 24 breaths per minute. And it is higher than standard. A lot of people using lung protective strategy shoots for about 15. Tidal volume, 6 the peak, somewhere between 8 to 12 to recruit some collapsed alveoli and improve oxygenation. And the FiO2 was at 100% starting for this patient. And it was going to be titrated down based on ABGs. The chest x-ray confirmed correct entitled or ET2 placement, and it did show a little bit of pulmonary edema consistent with developing ARD. And actually, lung ultrasound confirmed that there was no pneumothorax in this patient, which is a critical check after an intubation in case he got too vigorous with there. We also saw the curly B lines within that also, so that also confirmed pulmonary edema. All right, and I will move to my anti-malarial treatment of this patient. Now, I guess before I move, since we hit on the lung protective strategy, there is a obstructive pathology strategy of your patients, and that is used for COPD and asthma and patients of the like there. But if it's usually not those, we're usually going to move to a lung protective strategy. So my anti-malarial treatment, so alongside the resuscitation, as I talked about earlier, I administered IV quinidine. It was the drug I had, and the best drug you can treat it with is the one you have. Quinidine was historically the drug of choice in the U.S. for intravenous treatment for severe falciparum. It works by actually disrupting the parasite's ability to detoxify the heme, byproduct of the hemoglobin digestion, and it's toxic to the parasite if it accumulates. By blocking this process, quinidine kills the parasite inside the red blood cell. However, the global has already shifted. The World Health Organization recommends timonate as the first-line treatment of severe falciparum. That was based on the Aquamat trial, which demonstrated superior surviving outcome compared to and African children, and the Sequomat trial in adults in Southeast Asia. So I will say artesunate is faster acting, and it has a better safety profile and is more effective in reducing parasite clearance time. In remote field environment, quinidine may well have been what was available, or what the imperfect beats the perfect when you don't have perfect every time. I will say quinidine carries a significant risk that requires monitoring. Does anyone remember the effect that quinidine may have on the patient? And actually, I'll give you a hint. You need to use a ECG to find this. It's okay if not. It prolongs the QT interval, which can precipitate the life-threatening arrhythmia of torsades. So it also stimulates insulin secretion. It's another thing to look for, and that can cause hypoglycaemia, further hypertension. So all these risks are compounded in a patient who is all hemodynamically, they're unstable, they're in MODS, they're acidotic, and they have a vasopressor infusion going on. Now, one thing, we're expecting cerebral malaria with this patient, and actually On autopsy, he did have, and steroids are not indicated in cerebral malaria. And actually, they show, I didn't have the study off the top of my head, but the steroids worsen outcomes in cerebral malaria. So, question: why IV treatment versus oral or anti-malarials? Maybe if he walked in and he actually wasn't intubated from the IV quinidine. Say we gave him a oral anti-malarial, what would be the risk with this patient?
Dimitro, you have your hand up, bro.
Yeah, because this is the severe malaria, you can treat it only with the IV medications or IM medications. Like you mentioned, quinidine or artesunate, artemether. So oral medications are not useful for severe malaria type. And because of the low absorption level, and most likely most of these patients, they are not able to swallow medications. This one was, but I would also move to IV medications in this case.
Yeah, very good. Yeah, and giving a oral medication to a patient who is in multi-organ dysfunction, the likelihood of that absorbing, as you pointed out, is very low. It's not going to. You need to move to IV medications on this patient. So we'll talk a little bit about point of care ultrasound in the field, one of Aebric's favorite topics here. But it was used significantly and critically in this patient a few times. It's an indispensable tool in pre-hospital and austere medicine. CoROM has a great course with it. I recommend that you get your hands on it. It's becoming more and more affordable. At this point, the size-wise, you can fit it almost anywhere. So first, it was used to guide the internal jugular cannulation. And without ultrasound, central venous access in a shocked patient, it's a blind procedure, and there's significant complications. You can only imagine, arterial puncture. You can actually, if it's a long enough needle, you can actually cause a pneumothorax, a hematoma occur, and you can actually disrupt blood perfusion or increase ICP by inhibiting venous return. Ultrasound, you can see the vein, confirm its patency. You can watch the needle enter the vein in real time and dramatically reduce the complication. In a tent in Africa with no backup, that's enormous. Second, it was used to confirm lung sliding after intubation, which confirms that both lungs were being ventilated and that no pneumothorax had been created. And this is a critical safety check and is particularly important after the IG stimulation on that same side, as I talked about earlier. The lung ultrasound also identified the curly B lines, the ultrasound signature for pulmonary edema, which is consistent with that developing ARDS. And yeah, we did get a chest x-ray. So someone may say, well, why didn't you just get the chest x-ray earlier? When you're alone and doing x-ray, you're getting the cassette behind the patient. You have all this. It's much quicker to get the view of what's going on with this patient with ultrasound, actually moving to x-ray. But you're not going to be sweating in the back of your mind wondering if you actually have good on this patient. So other things, if I was more developed at the point, I could have had a good cardiac view of the patient. I could have looked at the left and right ventricular function. Is it really telling me, is the heart failing as a pump? Or is it being overwhelmed by fluid? I could look at the IVC collapsibility. It gives a real dynamic assessment of fluid status. There's really quite a bit that can be done here. With the low fluid urinary output, I could have done a bladder scan to see if maybe there was something more distal in line with this patient to make sure that they were able to pass urine. So it doesn't replace clinical judgment, but extends your reach significantly. I'll move on to the next piece of here. I have some good questions that ask about POCUS if you're wanting to look at those a bit further. So this patient was evacuated and with a critical care team, intubated, ventilated, norepinephrine infusion, and as stable as you could have hoped to have made them. Though truly they still weren't stable. They were just a little bit better than prior. And the handover was comprehensive. But even in the arms of the receiving team, the patient passed. The patient died. Patient was not compatible with surviving. So, and I want that to sit with you for a minute too. This was a hard thing to think about. As a young medic and someone dies, very much will blame yourself. May have done everything right. And as I believe a good job was done on this patient, and the patient was diagnosed rapidly. The guidelines were followed, pretty comprehensive care, more comprehensive care than probably was within hundreds of kilometers from this patient. The anti-malarial treatment was given. The patient still died. And this is a reality of medicine in austere environments. Sometimes the disease has progressed too far beyond what you or the patient or anyone else can see. 3 weeks of untreated Plasmodium falciparum malaria in a man in his mid-50s or early 50s had caused irreversible damage. At this point, the truth is there was likely nothing I could do to fully reverse this patient. The likelihood of the patient actually oxygenating enough with the parasitic load was very low. And what was done gave the patient the best chance, still was going to die, unfortunately. And that's something, as a question to you is, does this patient die? Does that mean the clinical care had failed? How do you separate the quality of the clinical decision-making from the outcome? And what does that distinction mean for how we evaluate performance in austere medicine? Something to give yourself as a question, and to kind of hold in the back of your mind. That way, you don't have a moral injury. Especially one that wasn't earned on a patient like this when doing the correct thing. One thing I didn't talk about was nursing care interventions for this patient. But what would some of the top nursing care interventions that you would see need to be employed on this patient? So if you're not familiar with nursing care interventions, I don't like calling it nursing care. It's not my favorite term for it. I think it kind of cheapens the role of what a nurse does. It's care that can be performed by anyone and everyone. It is predominantly performed by nurses, but some people feel it's below them. Oh, it's nursing care. And they may be a mid-level practitioner or a physician. If you're all that's there, it's still your care to do. Specifically, patients like this is you have to worry about the oral care of these patients. Worry about suctioning. You have to, one thing to really pay careful attention to, the pressure within the ET tube of this patient. If you just fill it up to 10 ml because that's what you were taught in paramedic school, or as you intubate, you're likely to cause tracheal ischemia on these patients. And that's a whole nother problem. Essentially, you're creating an internal tourniquet in that trachea. And the pressures that can be administered through the ET tube are 4 or 5 times the appropriate amount on there. Nifty resource. They do have some really cool syringes that have a manometer in them, and you can measure what that's at. And it is the size of a 10 ml syringe. But to likely have that, I rarely see one, and usually it's somebody brings one with them, and there's usually only one. Another way that you could do this is actually after you confirm placement on this patient and you come back, secure the tube, everything's in place, deflate the cuff and reflate it with 10 mLs, and then hold the syringe onto the bulb and let it equalize in pressure. And there's a CRNA program in the United States military out of a military hospital called Woolmac, and they showed that is very closely getting on target for what the right cuff pressure is supposed to be. And you just let that equalize. And once it equalizes, you disconnect it from there and do continue to watch your patient. But that's the recommendation they have. So key learning points. Let me bring this together. Lots of learning points from one case. The first and most important thing is disease is deceptive. 3 weeks of flu-like symptoms, walking under your own power, DCS of 50, an outrageous lack. Don't let that overassure you that the patient isn't critically ill just by initial patient presentation. Look at that whole picture. Second, your blood gas. Know that the difference between VBGs and ABGs. Drug selection matters, not only in the austere setting, the clinical course of our patient and what's going on with them. And again, back to the vecuronium versus succinylcholine, and also the ketamine versus a drug like propofol in the patient. In that ventilatory management is not just about the lung. So in a patient with severe metabolic acidosis, the ventilator is also part of the acid-base management. And also, we didn't get too much to it, but venous return as the way we normally breathe under negative pressure that help augment venous return. In a hemodynamically unstable patient, as we now put positive pressure, we actually are tamponading venous return and actually impairing that a bit. Again, a patient that's hemodynamically unstable, the one thing to augment cardiac output is, and that's exactly what we're disrupting. All right, and most powerful intervention in this case was not the intubation, it was not the vasopressor or the antimalarial. Most powerful intervention was really the recognition. The moment that to take this patient and go, oh, this patient is sick, and not only sick, but in sepsis, and they are on a razor thin edge here. That recognition is everything. It stops delayed treatment. It allows you to start culminating the resources you need to getting things in motion, and especially in the austere environment. To get a critical care team to me at that point, in the best of situations, is minimum 6 hours. And much likely, many times in that situation, was actually 24 hours. So even delaying the recognition by 3 to 4 hours can greatly affect my patient on there. All right. I have some references if you want to see some of where the, kind of read in on some of these things. ARDSnet on here. There's kind of multiple other publications that you can hunt down and read. And I believe most of them are open source at this point. You can find them somewhere, but do give those a read. And at that point, I'm going to turn this back over to Aebhric and answer any questions that you may have.
Fantastic. And that's one of the most difficult cases of malaria I've ever heard someone present. So, lads, we have some time. Who's got some questions?
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at corom.edu.mt.